All right, welcome to another episode of ICU Doc Talk. Thank you for joining me today. I'm going to talk about the cardiac ICU, meaning like cardiovascular ICU, meaning it's an intensive care unit that takes care of post-surgical cardiac patients, which is one of the main places that I work at my academic institution. So I'm an ICU doctor, I'm an intensivist, and that is one of the main places I work at. I'm going to talk about the different types of patients that come through these very intense ICUs. Right, these are very sick patients, and they come through and they just had extreme violence done on their body by a surgeon, and now we are there to take care of them. They often have many comorbidities. Oftentimes these surgeries are done in an emergency, which makes things a whole lot more complicated. And there are different types of patients that come to these ICUs. I'm going to try to categorize them and just give you an overall gestalt of what it's like to be in a cardiac surgical ICU. And just to give you a little flavor of what it's like. So let's do it. Okay, so there's like 5 or 6 types of patients in the cardiac ICU. Maybe I'll come up with more categories as I go here, or maybe I won't come up with as many. Anyway, there's kind of these different types of categories of patients that come to the cardiac ICU after having cardiac surgery. Now let's just back it up. What is cardiac surgery? Obviously, it's a cardiothoracic surgeon, a highly trained surgeon who does something to your heart. And there's many different types of operations. There's many different types of need that someone has in their heart. They could have coronary artery disease, meaning the coronary arteries, the vessels that supply blood to the heart, are diseased. They have blockages in them, atherosclerosis, and they need a coronary artery bypass graft, which we also call a CABG, which is referred to as like a bypass surgery, to help blood flow to the heart, basically. You can have valve problems, valve repair, narrowing of valves, regurgitation of valves. You need those to be replaced or repaired. You can have something called HOCM, hypertrophic cardiomyopathy, where you have there's part of your heart that is too thick and needs to be kind of carved out so you have better flow going through your heart. HOCM is a cause of sudden cardiac death, especially in young athletes. You can have there's so many different surgeries, right? There's just you can have congenital repair of septal defects like holes in one side of the heart to the other. You can have pericardiectomy, where they remove the sac around your heart. You can have repair of your aorta, like your ascending arch coming off. There's a lot. I won't go over all the different operations, but there's many different types. Now, someone can be nervous, so I do anesthesia too, right? And people are nervous, not all the time, but sometimes people are nervous before surgery. Like, say someone's having sinus surgery and they're a little nervous. And that's fine. And we try to help them through that if you need some pre-medication to take the nerves off, stuff like that. Now, me being experienced with all this, I would not be nervous. I've actually never had anesthesia, by the way. never had surgery. So it's kind of ironic. I have no idea what it's like to undergo anesthesia. Anyway, if I were getting surgery, I would not be very nervous. I was getting sinus surgery. If I was getting cardiac surgery, I'd be a little nervous. Okay, people who go in to have cardiac surgery, there's reason to be a little nervous about that. It's a major operation with high morbidity and mortality. Obviously, the vast majority of people survive. Otherwise, we wouldn't do this, right? But what's going on is that a surgeon is opening your chest, doing a sternotomy, taking a bone saw to your sternum and cracking it open, exposing your heart, and then oftentimes, usually, they're putting you on cardiopulmonary bypass, which is like ECMO, but it's more complex. Where, in order to do surgery on your heart, you can't have a bunch of blood in your heart, right? You can't just have a bunch of blood ejecting out of a hole. A surgeon creates your heart, just like a geyser coming out of the chest. They can't operate, and you're going to lose all your blood, and you're going to die, right? So that's why you go on cardiopulmonary bypass, which is a machine that continuously drains the blood from your heart and from your body, and replaces it while the heart is drained of blood, the cavities of the heart, so that a surgeon can operate. So that's cardiopulmonary bypass. It's a dangerous thing for your body to go under. Most people survive. It's mostly safe, but compared to other surgeries, it can be dangerous and it can cause problems. Okay, so there's that. That's what cardiac surgery is. So the first type of and then let's go back into what I'm talking about. I'm talking about the cardiac ICU, patients that get taken care of after. Just to give you a sense of how dangerous cardiac surgery is you automatically go to the ICU after surgery when you have cardiac surgery. Automatically, right? The ICU for at least for 24 hours to be observed, because that's how dangerous it is. There are so many things that can happen. You have to receive intensive care level of medical care to watch you, rather than, if you have sinus surgery, you go home. If you have cardiac surgery, you get admitted to the ICU. Okay, so I take care of these patients in post-op, and a whole cornucopia of things happen to these patients. Let me be clear: the vast majority of patients leave the ICU healthy and alive. Okay, the vast majority. So the things I'm going to tell you, these are the minority of things. Okay, so the first type of patient are patients that do fine, right? They do fine. So the first type of patient I'm talking about here, they come up to the ICU. They're usually still intubated from surgery, and you get sign out. Usually it's a surgical fellow and someone from the anesthesia team, either the anesthesiologist or a nurse anesthetist, and they bring the patient up. A respiratory therapist is there, and like the OR nurse is there. They escort the patient. They bring the patient up to the ICU, and they give a report of what happened in the ICU or what happened in the OR. And I get report, and I also get direct report from the anesthesiologist, the cardiac anesthesiologist who was taking care of that patient. Now, I get a lot of information about what this patient, and I've looked at the patient beforehand. If I could only know one piece of information, like if the anesthesiologist did the case, if they called me and they're like, hey, I don't have any time. I can only tell you one thing about this patient. I can't even tell you the case. I can't tell you anything. I can only tell you one thing, but you have to choose. What do you want to know? Do you want to know what I would want to know? The one thing. What is their preoperative ejection fraction? That's what I would want to know. If I could only have one thing. The ejection fraction is how much blood is your heart squirting out? How efficient is it being? For every pump, how much is coming out? A normal person's ejection fraction is like 65%. That's a normal healthy person. It's not 100%, right? The heart is not 100% efficient. It's not ejecting everything that comes into the cavity. So someone's preoperative ejection fraction, if it's low, if it's like 20% or 15%, that is a poor prognostic sign that the patient may not do well, because I say it all the time. It's very obvious. Bad hearts do bad. They don't always, but they often do. So someone who starts with a bad heart and then undergoes cardiac surgery, they often will do poorly afterwards. So when I know what their preoperative EF is, and if it's really low, I'm like, okay, we're in for it with this patient. Anyway, so I get sign up from patients. So the first type of patient I'm talking about again is patients that do really well. So they come up, maybe they had a single valve. Maybe they had something repaired, like a mitral valve. All right, their mitral valve was repaired, band annuloplasty, where maybe they have mitral or tricuspid regurgitation, and meaning the blood is going backwards up through the valve when it shouldn't be. It should be closed. The blood should be going backwards during systole, and a cardiac surgeon will come in and will repair the valve by approximating the valve leaflets so that they close more efficiently. So that's a repair. Or maybe they had a replacement. Maybe the valves were so bad that they had to be replaced. Maybe they had such bad mitral valve stenosis, like it was so narrow, or aortic valve, that it had to be replaced by cardiac surgery, which is a big surgery, right? Anyway, or maybe they had a simple CABG, which is a bypass graft for coronary artery disease. Simple CABG, 1 vessel, 2 vessel, 3 vessel CABG, or something like that. And so how the patients normally do, this is the vast majority of patients in this group I'm talking about, vast majority. They come up, you get a couple labs, their lactate is always high because they were on cardiopulmonary your where your tissues, non-pulsatile cardiopulmonary bypass, you're always going to be a little unperfused. I don't care how well you were flowing on bypass. Tissues, the body as a whole is going to be a little underperfused. Your lactate is up. Your body goes into anaerobic metabolism, and you're in a lactic acidosis. So these patients are always in a lactic acidosis, always. In my personal opinion, I think it's pointless to buffer them with bicarb or THAM. People who do it to correct a number to make it look better. All you need to do is give them more fluid and resuscitate them a little bit better. Maybe they need some blood also, whatever. Anyway, and then like an hour or two goes by, you wake them up. They wake up just fine. And you take the breathing tube out. 2 hours later, they're great. They're up. You control their pain. Maybe they got a pain block. And they're good to go. And they leave the next day. They leave at it. You watch them overnight. You make sure nothing bad happens. The two big things I look for there's a lot of things I look for, but some of the biggest things I'm looking for up front are, these patients come up with chest tubes, right? They have mediastinal chest tubes and they have pleural chest tubes, which is a window into the bleeding around what's going on in the heart. Two things I kind of look for are they bleeding, right? Is a bunch of blood coming out of the chest tubes? Is it like 30 cc's an hour, or is it like 100 cc's an hour? Does the nurse come up to me, hey, they put out 200 cc's the last 30 minutes? Like, oh, the patient's bleeding. And when I say bleeding, it's oozing. The tissues that have been resected are slowly oozing still. They're not clotting off, right? If they're having a major bleed, like a big vessel, they would bleed out very, very quickly, and they would need a bedside sternotomy if they're bleeding like that, which is something I'll get to in a moment. So I'm looking for bleeding, and I'm looking for tamponade. So someone can bleed, and they're bleeding a ton, and sometimes the surgeon needs to take them back down to the operating room, open their chest back up, and dry them up. Meaning maybe there's a tiny little venous bleeding, whatever. They need to go in with cautery and just buzz in the surgical field and dry that chest up and sit there for a while, make sure, and then close them up again and bring them upstairs. So that does happen. It's not uncommon. It's very frustrating to patients' families. Like, they're like, oh my gosh, they have to go back down. And I try to reassure them. Sometimes I can't. But sometimes it's like, this does happen. A certain amount of the time, you have to go back down. And these patients, they do fine. It's not a big deal. It's a big deal, but it's like, in the grand scheme of things, like, just take them back down and try them back up. And then I look for tamponade. You can have tamponade with chest tubes in, right? So often we classically think of tamponade as blood or pericardial effusion around the heart. That's like a vice. A tamponade is like you have too much pressure in the pericardium, or not even the pericardium, but, well, yes. Around the heart, and it's pushing the heart so much the heart can't pump anymore. You can have that, right, with blood. You can also have that with a clot, which is sometimes what you can see in post-op cardiac patients. They have a huge blood clot that's like sitting on their, RA or their RV or their LV, and maybe you can't even see it that well on echo, but it's just sitting there, and it's just pushing into the ventricle, and they're not pumping blood very well. So that's another thing I look for. Kind of the immediate post-op period, a few hours after coming up. Okay, so anyway, there's this one type of patient is they do fine. They have some sort of surgery on their heart or their heart valves or their aorta, and they do fine, right? And they fly, and the next day they leave. So that's one type of patient. The next type of patient are those that are disasters. Fresh post-op, they're disasters. Okay, like you get them. These are the people that maybe they had an EF of 20% preoperatively. Maybe their cardiopulmonary bypass time, the time they're on bypass, or cross clamp time, the time that their actual aorta had a clamp on it. Maybe that was very long because the surgery was technically challenging. Because this is their 5th time getting a sternotomy, and there's tons of scar tissue, and it's very challenging for the surgeons to do that in a timely manner. Or maybe it was an emergent procedure. Maybe they had a heart attack, and they were getting an emergent CABG, like a bypass. Or maybe they had a type A dissection, where the first part of their ascending aorta was, the inside of it is peeling off the outside of it, which is a surgical emergency. So maybe all these things happen in an emergent setting. So anyway, and they come up, and it's a dumpster fire, meaning like they come up and these patients are on 3 or 4 pressors like epinephrine and norepinephrine and vasopressin, and extremely high doses. They're in total shock, usually cardiogenic shock. They're going into multi-organ failure quickly, and I am putting all of my effort and all of my attention at that patient at that time to keep them alive. So there's that kind of patient. And maybe they come up on ECMO. That's another category of patient that I will get to. Because sometimes patients are so bad, they're in such bad condition in the operating room. And this isn't the fault of anybody, it's just this is the way cardiac surgery goes, that they can't be separated from cardiopulmonary bypass, and they get placed on the portable ECMO machine, which is a heart bypass machine that's portable. and they come up on ECMO. Here's a story. I was up in the ICU, and the anesthesiologist covering a cardiac case called me, a patient that was coming to me, and was like, hey, this patient is like in their 90s, and the surgeon wants to put them on ECMO down here. I was like, can you come down and talk to them? The context is, the reading between the lines, it was, hey, I don't think we should put this patient on ECMO. Can you come down and talk to the surgeon about not putting the patient on ECMO? And I was like, sure. I knew coming down and then coming to the operating room, it doesn't matter what I say. That surgeon will put that patient on ECMO. Surgeons, it's their decision, right? They don't care what anybody else has to say. If they're operating on a patient, and for better or worse, I'm not being critical of this. For better or worse, if a surgeon is doing surgery on, if a cardiac surgeon is doing surgery on a patient and they can't get the patient off ECMO, cardiopulmonary bypass, they are putting that patient on ECMO and they're bringing to the ICU. They do not care about any other people's opinion. Maybe they might care. I don't want to speak for all surgeons, but they're doing it, right? They're not going to let that patient die in the operating room. And I actually agreed with the decision, despite the fact that the patient was 91, 92, whatever. It's like, you know what? This patient came in electively for a cardiac surgery, and they can't quite get off. I was like, I think it's very reasonable, despite them being in their 90s, okay? Despite being in their 90s, I think it was reasonable to give them a time-limited trial, 48 hours or something like that, to see if they recover and see if they get better. And if not, then they'll pass away, and that'll be the way that'll go. So I actually didn't have a problem with this. For this type of patient population, a post-cardiotomy patient, not like an emergent patient who's having a heart attack in the emergency department who's in their 90s, that patient should not go on ECMO because their chance of survival is terrible, terrible. Anyway, okay, so there's that type of patient. They're a disaster, and I'm working the next 12, 24 hours, really trying to resuscitate, not resuscitate necessarily, but keep them alive. And they are going through myriad problems. And then this group of patients, then they pull through it. And they're fine. It happens. So even when they're like a dumpster fire, they usually do. They'll pull through it. Sometimes they don't. They pull through it, and then they do okay. And I mean okay, like they'll get through it. They get, maybe they're just in vasoplegia, which is like a vasodilatory shock state that people come up on. And sometimes that can take 12, 24 hours to go away. So there's that type of patient. And then the next type of patient are the dumpster fires that don't do well, and then they die. Okay, so that's some of these patients, just they linger. You keep trying. You give them methylene blue. You give them a cyanokit. These are last-ditch efforts to keep their blood pressure up. You have them on angiotensin II. You're doing everything you can, and they're obviously multi-organ failure, and they're obviously going to die. And then they die. You talk to the family. You have the surgeon talk with them as well, and they die. So this is a very tiny minority of patients that die like this. And then the other category of patients, I don't know, this is like third type of patient. It's the patients that do terrible, but they keep surviving. They live, but they go into like kidney failure, right? And then you have to put them on dialysis, and then you can't feed them for a while because you worry about gut ischemia, or maybe they have some gut ischemia, and another surgeon needs to take them downstairs and cut out some of their dead bowel, and they just linger in this terrible clinical state, but they're alive and they wake up when you try to wake them up, and then they're in this state and they kind of start getting better, and so you put a tracheostomy in because you can't quite liberate them from the vent, and then they're on dialysis, and then they come out of shock. And they start to get better, but now they have total kidney failure, and they're trach dependent, vent dependent, and so they have survived, but they have suffered serious organ injury, and now they are in the ICU for like months, trying to rehab, and we can't quite get them out of the ICU, meaning we can't get them down to a more step-down unit. There's that type of patient, right? And they will linger in the ICU for a long time, and they'll have setbacks. Maybe they'll even code. They need some chest compressions. You shock their chest. They go into VTAC. All the myriad things that can happen, can happen to this type of patient. And then eventually, one or two things happen to these patients. They finally get like another pneumonia. They all get like a pneumonia, right? It's like a VAP, ventilator-associated pneumonia, or they get septic. They get bacteremic. They get a bloodstream infection. They usually will something will happen, and they will code, and they will die. Or they finally get a little bit better, and you can finally get them out of the ICU. And maybe they'll bounce back to the ICU a week later, maybe not. And sometimes they finally, they get the trach out, and then they have kidney recovery, but oftentimes they do not, and they become dialysis dependent, 3 days a week, and then maybe they can eventually go home. So there's that. Okay, so that's kind of that patient population. Let's talk about ECMO patients. So there's different types of ECMO patients. ECMO is not just like, hey, let's put this patient on ECMO. There are different clinical settings in which you put patients on ECMO. One of them I already mentioned, post-cardiotomy, meaning a surgeon electively agreed with a patient to take a patient back to surgery. During surgery, they do poorly. For whatever reason, they cannot come off cardiopulmonary bypass, so they are placed in ECMO, and then they come to the ICU. So they come up, and they're on ECMO. So it's kind of an unplanned ECMO, which a lot of ECMO is unplanned. Some of it's planned, which I'll get to in a second. So these patients come up, and they're, as I said, they're the disasters. But they can, these patients can go a certain way. Sometimes they will persist on ECMO for a long time, and the surgeons have a lot of say in how long they want a patient to be on ECMO, which I get that. I'm not going to really talk about that. There can be disagreements and things like that, but decisions must be made together with the whole care team. You can't unilaterally act, and in conjunction with the patient's family. I've been in many circumstances where a patient's family wants to say goodbye. They're like, hey, the patient doesn't want to be doing this. Why are we doing this? Why are we doing this? And the surgeon wants to keep going, and it creates a lot of conflict. It's a moral conundrum. It's a very difficult situation to be in, and it is fortunately not that uncommon. So that happens. So anyway, eventually sometimes these patients will get better, like they'll turn around in the next 24, 48 hours, and then, you take a look at their heart, you keep looking, is it recovering, are we able to get them off ECMO? And they're on ECMO because of cardiogenic shock. They're on ECMO because their heart is not working. They're not on ECMO for vasoplegia or like septic shock, right? ECMO, vasodilatory shock, meaning where your blood vessels will not vasoconstrict, that is not an indication for ECMO. ECMO will not help those patients, right? ECMO is a pump. It's not a restrictor. It's not a vasoconstrictor. ECMO does not help with vasoconstriction. It's just a pump. I say this because sometimes you get post-cardiotomy patients they're not on ECMO. They're not doing well. They're in vasoplegic shock. And then someone will be like, should we put them on ECMO? And the answer is no, you don't, because it won't help them. Because if their heart is working and they're just in vasoplegia, ECMO won't do anything. You're not going to fix their vasoplegia with another pump, right? Okay, anyway, so there's that type of ECMO patient. There's the emergent ECMO patient, this is the type of patient I put ECMO. This is the type of patients ECMO that I put patients on myself. With my hands, I put patients on ECMO. This is when it's emergent, where like someone's in the cardiac ICU, not initially the cardiac surgery ICU, the cardiac ICU, and they're in refractory VTAC, or they're maybe, I don't know, or they're in the emergency department. They came in and they had chest pain a day ago, and now maybe they have a heart attack. We're doing chest compressions, and we emergently place them on ECMO, usually femoral access. And these patients usually don't do well, right? This is a patient population they're getting chest compressions. They may have poor neurological recovery. They may have neurological injury from being in a low flow state. And they're put on ECMO as a last-ditch effort with fairly stringent selection criteria, that is part of my job, to select in that moment, hey, should I put this patient on ECMO? And then we place them on, we bring them to the ICU, and we do things to them to try to get them to survive. A lot of these patients eventually die because we finally scan their head and they have a huge stroke, or now they're in multi-organ failure, or their heart is just dead. And eventually a lot of these patients are, we take them off ECMO and they pass away. Sometimes not. Sometimes, hey, maybe their heart recovered to like 20%, maybe we can, and they're neurologically intact. Maybe they can have an LVAD, which is a permanent, basically mechanical pump that is placed, around your heart by a surgeon. Or maybe they're a heart transplant candidate, and that's my next category of patients that come to the cardiac ICU are transplant patients, right? Heart and lung transplants. Well, let me round this off with ECMO patients. A lot of times, in an elective manner, you'll have a patient who is in end-stage lung failure. They have interstitial lung disease, like IPF, or usual interstitial pneumonia, whatever. And they're not doing well. They're on very high flow nasal cannula. They're on a face mask as well. Usually this is what this patient looks like if you're curious. So I get consulted about these patients. Usually they're in the medical ICU, and I get a call hey, I think maybe we're ready. This patient is a transplant candidate. If they're not a transplant candidate, I do not put them on ECMO. But it's okay, they're a transplant candidate. Come take a look. Usually what this looks like, I go into the patient's room. They are on high flow nasal cannula, maxed out. right? It's like 100% FiO2, flows are maxed up. And they're on a non-rebreather as well over that. And they're tachypnic in the 30s or 40s. And I'm talking to them, and they can only say about 3 or 4 words at a time to me because they're so short of breath. They basically can't walk around anymore. In my opinion, and this varies, right? In my opinion, we should put that patient on ECMO now. Put them on ECMO. You place them on VV ECMO, and then you can intubate them for ECMO or not. You can do it while they're awake. Usually, you have to intubate them because they can't lay flat because they're so short of breath. Anyway, you put these patients on ECMO. You can extubate them. They walk around. They rehab. They don't get deconditioned while they wait for a lung transplant. And you do this also for heart transplants. So that's another type of ECMO patient. They are waiting to get organs, and then they go down to the operating room and they get lungs or heart put into them. So that's another type of ECMO patient. Anyway, and then we have heart and lung, and then we have the post-op heart and lung transplant patients, right? So a lot of these patients do really well, right? A surgeon puts a new organ in them, a heart, whatever. And like 24 hours later, a lot of these heart lung transplantations can be extubated. They can be on very minimal inotropic support, meaning like not a lot of epinephrine, or maybe my institution sometimes we use isoprotenolol. Some institutions I know use dobutamine. This is all very institutional dependent. You might be, the things I'm saying, if you work in a cardiac ICU and you're listening to this, you're like, oh, we don't do that in my institution. That's just because that's just what your institution does, and that's what my institution does. There's not a lot of evidence behind these practices. It's very dogmatic. That's one of my main big take-homes. Here's one of my big take-homes about what I'm talking about cardiac ICU. It's the Wild West. What I mean by that, it is a hard place to be evidence-based a lot of the time, because how do you run trials on this patient population? You can't run randomized control trials. It's not very ethical. So a lot of it has to do with just the provider that's in charge and what they want to do, like me as the intensivist or the surgeons, right? I can't tell you how widely the practice of putting someone on anticoagulation is after getting a valve, like a prosthetic valve or a mechanical valve. It varies from surgeon to surgeon to surgeon to surgeon, right? So that's why it's like, hey, when should we start the patient on aspirin or Plavix or warfarin or rivaroxaban or subQ heparin? When should we do that? And I just say, what does the surgeon want to do? Because that's what we'll do. Because this is such an evidence-free zone, and the surgeons want so much control, as they should. I think they should have control within reason, because and decisions should be made within, and because it's a lot of times it's an evidence-based free zone, we'll just defer to them. Now, a lot of times there is evidence, and surgeons will go against that evidence because of their own anecdotal experience, which is probably not good, right? So that is happening as well. Anyway, so you have heart and lung transplant patients. Some of them do very well. The majority of them do. Some do not. They have graft rejection. They go into organ failure. Sometimes they need to be placed back on ECMO because their new organs are failing. They need to be put on VV ECMO because their lungs are crap or the heart's not working. They're having graft rejection. And then they're even listed for a transplant, and they'll get another transplant, right? And then we'll put, they'll put another heart in them, and hopefully that heart will do well. So these are very complex patients. Lots of different people are taking care of these patients, right? Many. Let me just talk about all the different people that are involved in this, right? There's not just me, the intensivist, nurse practitioners, physician assistants, charge nurses, the nurses, respiratory therapists, physical therapists. There are all the consulting physicians and their teams, like the kidney doctors, the infectious disease doctors. And then you have the surgeons that are involved, right? They're heavily involved, that I heavily talk to every day, and we're all trying to make decisions. You have the pharmacists. You have more people that I'm leaving out. And you have specific transplant doctors, heart and lung transplant. They specialize in transplantation, right? Not just cardiology, not just pulmonology, but also in transplantation and the immunosuppression, managing the immunosuppression of these patients. Very complex stuff, and lots of people have their eyes on it to try to get these patients to, what's the whole point? The whole point is to get these patients home, right? That's the whole point. We're trying to help people get better, and it doesn't always work. These are decisions you have to weigh with it when you're talking with a surgeon about getting one of these surgeries, right? Depends on your state of health, depends on your age, depends on your life goals, and depends on, you should review the statistics. What is your chances of getting out of here? Are you okay with dying? Are you okay with your loved one potentially dying from this? Again, we wouldn't be doing these things if most people didn't leave alive and with some sort of quality of life. But the downside of it is that people don't get better, and they'll die in circumstances that they would rather not have. Anyway, that is the cardiac ICU in a very small nutshell. It's a huge world with lots of complexity, and it's a very exciting place. It's a very exciting place to work. It's also very exhausting. It's very draining. It's emotionally, psychologically, and physically draining. I am not a person that is. I am blessed and fortunate enough to not have depression, and it's not something that I've struggled with in my life. Every now and then, after a week of being in the cardiac ICU, I have noticed depressive symptoms in myself that are very fleeting, fortunately for me. And I get over it, I recover. It doesn't happen very often. I usually go through a week and it's fine, and I'm fine. But I'm just saying, like I am a person that is not. I'm fortunate to not have problems with mental health, at least that I'm aware of. And yet, despite that, it still happens to me a little bit. It can get to me. So I can't imagine someone who does struggle with depression or feelings with other issues with like life being trivial and things like that. It can hit even harder. So it can be a hard place to be, but I do enjoy it. It is a rewarding part of my career. Anyway, there it is. There's a little bit of cardiac ICU. Let's move on. Okay, let's talk about a book, nonfiction book. This is called The Dawn of Everything, A New History of Humanity by David Graeber and David Wang. If you know anything about me, you know I'm a huge fan of David Graeber. He passed away like 2 or 3 years ago, I think of a stroke or something. He's an anthropologist. He's also a self-proclaimed anarchist. He wrote Bullshit Jobs, and he also wrote Debt the First 5,000 Years. I think 2 books that I have talked about on this podcast. He is a really interesting person and a towering intellect. I don't want, when I talk about him, I don't want the term anarchist to throw people off. For one thing, I don't think people even understand what anarchy, like most people, probably most, maybe not all, but many people don't even understand what anarchy is. When they think of anarchist society, they think of it as being like mayhem and nobody's in charge. It's true, nobody's in charge. Nobody is truly in charge. It's basically, I don't claim to understand everything about anarchy myself, and I'm not an anarchist. I think it's an extremely interesting way of running societies, but it's basically there's no centralized power. Anarchy has a lot to do with libertarianism, but there's conservative libertarianism and there's left side libertarianism. Anyway, this is pertinent to this book. Basically, to sum up this book, nothing about our current social structure is inevitable, like we seem to think it is. So this book, The Dawn of Everything, is a prodigious and ambitious take on how societies actually form. And the authors tear apart all the assumptions about our current sociological arrangement by looking to our Neolithic past, right? These are anthropologists. The main point of this book is that the current social structure, one in which almost every human being is subject to state authority, is not the culmination of an inevitable series of events. Meaning, the current social arrangement is not the consequence of natural sociological evolution. The myth has to do with the dichotomy between Rousseau and Hobbes and the modern-day quest for equality. All right, so the Rousseau myth evokes a picture of infantile humanity living as simple bands of foragers who were naturally egalitarian, and that modern day we are seeking out a similar arrangement. What the authors do here is treat Neolithic people like knowing, self-aware adults who didn't form autonomous societies because it was a natural inclination, but that it was an active choice they were making, fully aware of and rejecting authoritarian rule. So they respect, like Neolithic people were human beings just like us, just like genetically, all these things, they're just like the same brains, everything. So many. The amazing thing about this book is it is full of research. So there's so many examples abound in this book of past cultures understanding the dangers of power and forming their societies in such a way that provided safeguards against the tyranny of concentrated power or state power. The modern Enlightenment about the quest for equality probably came from American indigenous intellectuals critiquing the Western power structures. When like French colonizers and philosophers came to the Americas and spoke with indigenous intellectuals, the indigenous intellectuals were like, "What's up with your society? You're all like under a central authority and you're basically slaves. And that influenced like people like Rousseau. When we look back and see the absence of state power, we project our own acceptance of this inevitability, and we believe that these past societies hadn't achieved anything close to modernity, when the reality is that they were much more in control than we probably are. There is a huge catalog here of societies functioning with great, incredible complexity, agriculture, art, and city planning without any central authority or monarchical rule. Now, of course, there were plenty of societies that did have central authority, but the point is we are not the zenith of human civilization like we think we are. Maybe technologically, right? We are probably just trapped in a very large cage that we call modernity. In a way, this book is the answer to another amazing book by Jared Diamond called Guns, Germs, and Steel, which the authors reference a couple times, and with a little derision. That book asserts that there's this incremental progression into modernity that comes about because of agricultural and geographical determinism. Only agriculture does not necessarily lead to concentrated division of labor, as these authors definitively show. And agriculture does not necessarily lead to private property and central rule, as the authors demonstrate over and over again. We constantly project our own modern pathologies when we look back at the past of the people. The authors argue there are three ways people get power, how you maintain power. Control over violence, control over information, and charisma of personality. The modern state clearly has harnessed these three things very, very well. All right? Just think about why, if you're in the United States, think, why is the United States in power? Control over violence, control over information, and charisma of personality. It sums up our political landscape, and it sums up why the United States government has power, or any nation for that matter. Neolithic societies probably understood these levers of control, and many cultures arranged themselves in such a way to prevent anyone from co-opting these levers to then create central control. Sometimes it happened, sometimes it didn't. What these authors do is they upend the modern concepts of equality and freedom. They talk about three basic freedoms that many Neolithic people enjoyed. Here they are. Okay, this is really, I love this. They had freedom to move, freedom to disobey, and freedom to change their social structure. Let me repeat that. Freedom to move, freedom to disobey, and freedom to change the current social structure. Do we, meaning the vast majority of people who lived under state authority, right, in the world, do we enjoy any of these freedoms right now? Not really. No, we don't, right? And the truth of the matter is our ancestors likely had a much better grasp on how to run a society than possibly ourselves, which is a realization that has made this book so striking to me. Here's the take home from this book. Most modern day state and political power is arbitrary. It's arbitrary, and most of it is not justified. This book I would consider a must read. I think you definitely should read it, along with David Graeber's two other books that I already mentioned, Bullshit Jobs and Debt, The First 5,000 Years. These three books will probably change your perspective on society more than anything that I could recommend to you, and I highly recommend it in a good way. Like, good things will happen in your brain as you read those three books. So this book is called The Dawn of Everything, A New History of Humanity by David Graeber and David Wang. It's probably like 500, 600 pages, but highly recommend. All right, let's go to an email that someone sent me a great email from a nurse. I won't go too much in detail about who sent it and everything they said, but I think they asked a good question. I just don't want to reveal who they are. Maybe it's too sensitive an email, but I'll just keep it anonymous. This person is a nurse, and they're considering going to medical school. They're a nursing student. They're a fourth-year nursing student. So they're saying, as I finished my nursing studies, I found myself struggling with the thought that I should have pursued another undergrad degree and then continued on to medical school. So they recognize, nursing profession is incredible, and they are incredibly proud to be entering the field, but they can't feel that they should have pursued a higher level of training. Let me see. So while it's easy to say, follow your dreams, become a physician, I also know I have to consider the serious investment I have made in my education thus far if I were to take on an even larger financial burden in pursuing med school. This person's a first-generation college student and the only one in a family to pursue a career in healthcare. So they're reaching out, asking for advice about what I think about switching careers like that. So for one, I've emailed a response to this person, but I think just if everybody cares about what I have to say about this is like, for one thing, is someone making a decision like this, no one, and this is obvious, and it goes without saying, only you can make this decision. Nobody can make the decision for you, obviously. The advice to follow your dreams is awesome, but yes, you do need to be practical, and if it works for you, then that's good. If not, then maybe it's not something realistic to pursue, like to go through a bunch of training and then do a 180 and then go do training something else. Now, I've known many people who have done stuff like this, right? I knew someone who went to medical school. No. Became a pharmacist, a full-blown pharmacist, practiced as a pharmacist, then went to medical school, then did half of a radiology residency, and then stopped doing radiology residency, and then went back and started an anesthesia residency, right? I've known people that have dropped out of surgery to go to anesthesia. I've known people that have completed, doing dermatology and then become critical care anesthesiologists. Like, it's not unheard of. I think you need to weigh a lot of things, and one of the things that we face, as a newer generation of healthcare is student loan debt. It's a huge burden, and medical school is, if you take out full loans, is at least $300,000, $400,000, particularly if you're paying for your housing and things like that. And then if you don't go into that high of a compensating of a medical career, like family medicine or psychiatry or others, then it's even harder to pay off those loans. So the financial aspect must be considered. And then another thing to be considered is family planning. Like, what are someone's family goals? Like, does someone want to have a family in the traditional sense, meaning children, marriage and children? For some people, that's a huge priority. For some people, it's not a priority at all. They don't even want to do it. All right. So that obviously is a huge consideration. I'm not saying anything earth-shattering here. I just think you need to weigh all these things together. There probably has to be a compromise, because I don't think you can achieve all of your goals together. When you're going to stop a current line of training that you're in and then go pursue something else. What I will say is, who cares what age you are when you do anything? That doesn't matter, right? I remember back when I was in undergrad, and people were like, "Oh, wow, you want to try to go to med school? That's a long road. You're going to be whatever in your mid-30s before you're even practicing." It's like, yeah, well, I'm going to be in my mid-30s anyway, doing something else. Like, I have never understood that when people say that. Like, age doesn't matter, and the schedule that you do things is totally customizable. It doesn't matter if you haven't, if you do things non-traditional, like, oh, I didn't start med school when I was 25. Like, who cares? That's good. Have more life experience, you'll be a better doctor, right? Because you'll learn how to talk to people like a human being and not like an automaton. Anyway, this has been a rambling answer, but I hope that helps. All right. Lastly, for this episode, I'm going to move on to reviewing a fiction book. So you can hop off if you don't care about sci-fi or fantasy, because that's what I'm going to be talking about now. And then this episode will be over. Okay, the book I'm going to talk about is The Sword of Kaigen by M.L. Wang. This is an amazing book that won one of Mark Lawrence's, SFFBO or whatever, fantasy competition. And it's an indie publisher. It's probably been picked up by a publisher now. I forget. It was published in January 18. It is amazing. This book is like stunning. It's tragic. It's raw. It's beautiful. It's a Japanese high fantasy that like blends realistic characterization with a very well conceived magic system, and it's a very compelling story with incredibly fleshed out characters. There's nothing like this book out there. You should read this book immediately. It's amazing. It will not be what you expect it will be. At the onset, the author lays down some really good exposition. It's a little tedious at first. It takes a little work getting into the book, but slowly the reader learns, the patients, the characters' names, backstory, and a little lore about the world. And then once you become hooked by the realism of these characters, namely Misaki, who is an isolated woman in a loveless marriage with magic-wielding children that she doesn't understand, you're really eager to read on. I quickly learned like the depth of the main characters and felt as if they were real, and they had very relatable issues. So the author Wang sets this up, and then she smashes everything with really broad strokes. The pace and the plot take a total 180. They leave you and the characters very disoriented. The plot is unpredictable. The pacing is really superb. The overall story structure is totally unique. And just like in real life, the story is messy and it doesn't follow a predictable arc to which a fantasy reader might be accustomed. The characters are beautiful. Masaki's isolation, her self-doubt, the tragedy and endurance of her life make her one of my favorite modern epic heroines. Masaki is so well fleshed out that I could predict. Well, I don't know if I could predict, but the way she behaved in scenarios just made sense based on how well her character was set up. This book, The Sword of Kaigen, successfully explores many themes: patriarchy, tradition, sexism, motherhood, fatherhood, propaganda, government roles, geopolitical warfare, misinformation, loyalty, and all the gray lines in between all this. These themes are not just touched on, they're expounded. For example, the storytelling. Through the storytelling, I began to understand why the patriarchy was in place and why Masaki's husband, Takuru, behaved the way that he did. Men are not just like simply vilified here. Rather, Takuru's behavior, her husband, starts to make total sense based on his backstory. Not only do all characters have an arc, but the culture in which they live also has an arc, as the patriarchy takes on a new form. This book is also very sad. Strength through tragedy is probably its strongest theme. The world building is solid. There are many cultures, languages, and people that I really wanted to get to know even more. It makes me excited to read more stories that take place in this world. The magic system starts out derivative, just like any magic system, but it becomes more integral to the characters, giving it more depth. And I forgot to mention the action in this book. It's awesome. There's incredible warfare and magic-wielding battles unlike anything I've ever read in fantasy. I highly, highly recommend this book. I would consider it a masterpiece. There's nothing like this out there. It's called The Sword of Kaigen, Kaigen, by M.L. Wang. Put this at the top of your list. Read it. Anyway, that's it for today. Thanks for listening. If you want to get a hold of me, email me at icudoctorecmo@gmail.com. My TikTok handle is icudoctor, and I'm on Instagram at icudoctortiktok. And let me know about, so sometimes I just don't record episodes because I have too much stuff going on, but also sometimes I'm just not that enthused about it. What can get me going is someone sending an email being like, hey, talk about this. I'm really into this. And that will inspire me to record an episode. So if a couple weeks go by and I haven't recorded anything, nudge me with an email and be like, hey, talk about this. And if it's something I'm like, hey, yeah, I'm into that, I will do an episode. So anyway, thanks for listening. See you next time.